Here at CP Lamont and BRI, and I'd also like to welcome all our online participants. So it's my pleasure right now to introduce Dr. Simone Dahrouge and Andrea Perna, and they're going to be talking today about improving equitable access to resources in the community through primary care integration. Simone, as we know, is a scientist and our leader here at CP Lamont and the Bruyère Research Institute, and she's the Vice Chair of Research for the Department of Family Medicine at the University of Ottawa. She's an epidemiologist and has a doctoral degree in population health from here at U of Ottawa. She's PI on over $8.5 million of current active CIHR awards. Very impressive. And her current research is in the area of population health and primary care, more specifically focusing on how primary care can be organized to optimize service delivery, quality, and equity of care. Dr. Andrea Perna has been working as a research associate with Dr. Simone since December 2016. And in this capacity, she is primarily responsible for coordinating the Access to Resources in Community Care project. Andrea has also an MSc in neuroscience from Carleton and recently obtained a PhD in population health from the University of Ottawa. She's also has almost a decade of experience in health research and expertise in quantitative and qualitative research methods. Her background includes research on stress, mental health, stigma, and vaccine hesitancy. So without further ado, Simone.
Thank you. Okay. So let me just make sure you know how to do this. Okay. So today we're going to tell you about a study that we're doing. It's actually two phases, a feasibility phase, which is underway, and a randomized control trial. And at the end of the discussion, at the end of the presentation, I'd like to have a discussion around two, but especially one key issue. So put your thinking hats on. We need advice on best design because we've gone around the block, talked to methodologists, statisticians, and we're just not sure what's the most feasible approach. Okay. So there's a large research team. This is funded in part by CIHR and there's a SPORE initiative through the Impact Grant. The CIHR is through the CBPHC grant. We have partners, so this is one of those, like the first initiative that I'm doing that really has this broad partnership that's not just health planners. We've partnered with health planners before, but we have patients, we have care providers, so we're really well surrounded with people who can advise us on this. No conflict of interest to declare. So we're going to give a little bit of background on the subject matter, describe the intervention, describe the study that we're doing now, which is the feasibility, and tell you what our next steps are, and then hopefully get your input on things. So the CIHR grant, the CBPHC grant that we had, was focused on improving access to primary health care for vulnerable populations. This was in 6 regions, and each region had to identify its priorities. So it had to work with its own stakeholders, identify the gap, develop, select an intervention, develop the intervention, implement and evaluate it. And then the Impact Grant came to bolster the implementation and evaluation through a randomized controlled trial. So we started with a lot of consultation, really broad consultations at the beginning with the LIN, with sort of all the leadership team in the LIN. And we asked them, what is the current barrier to access to primary health care in the region? And they said, well, we have a lot of resources in the community, but they're really underutilized. And the Auditor General's report a couple of years ago said that 90%, they had an initiative in improving self-management in diabetes, and 90% of the educational components were underutilized. So it was multi-component, but the one component that was supporting patients in self-management, they were undersubscribed. So it's an issue. We have resources to support patients, but they're not using it. So as a result, people are not accessing services that can improve their health, and they have increased unmet needs and deterioration in health. So what do I mean by community-based resources? So we're talking primary healthcare. Primary care is in the practice. Primary healthcare is much broader. Sometimes it's in the practice as well when we have interprofessional teams and services that are offered. And sometimes a lot of it is in the community. And we mean primary healthcare in the really broad sense. So it could be things that are really around health that we can immediately think of, like diabetes self-management, falls prevention. And then it could go to more sort of social habit, which is part of primary healthcare, healthy eating, exercise, smoking cessation. And it can also address the determinants of health. So adequate transportation, housing, finances, and so on. So it's all these services, health and social services. We refer to them as health enabling resources that are in the community that people could access, but that we're not accessing. Oh, okay, so I guess I was meant to go through each one of those. So seniors' health, for example, so in fact, so one of the practices that we're in said to us, well, you know, we don't know really what we want to know about. We said to them, listen, you can refer to whatever you want, but you can tell us what your priority might be. And they said, well, you know, the seniors. And so we said, well, there's falls prevention, there's foot care, personal care, there's friendly visiting, because we know social isolation is a huge problem. Home maintenance, transportation. I guess we can go through all of these. Chronic disease is, you know, pretty obvious. This is something we're really well aware of, cardiovascular disease and other self-management, the healthy living, smoking cessation. Mental health is a big component of what people are interested in having their patients access. And then all these social services, immigrant support, parent support, and so on. Okay, so the next step was to determine why we were not accessing the resources adequately. Well, in primary care, patients are referred to secondary care, so they're referred to specialists. There's a process, and there's a referral, and patients go to those services. We know where they are, we find out. But these services are ever-changing. They're not clearly advertised. We don't know where to get the information. We don't know the breadth of the services that are out there. And primary care providers make recommendations for, you know, smoking cessation. They might say there's resources out there, but rarely do we know what is out there and which one is best for the patient. Because, for example, smoking cessation, there may be several places. Which one is best for your patient? And it's not within in terms of opportunity costs, it's not something that the physician can take the time to do, to go over these resources with the patient. So they have limited awareness and they have limited time to look for the information and share it. Primary care patients, we have focus groups with them. So this is work that we've done, interviews and focus groups. Lack of knowledge, they don't know where to find the information, and then when they do find some information and they try to go, they're really frustrated because, oh, maybe they weren't eligible. And then those patients who are most complex, who are most likely to need these services, well, they have barriers, additional barriers to getting to these services. I know that some primary care providers will have said to me that, well, I can think that this patient needs this, but I can recommend it, I can really encourage it, but they're just not going to be able to get there because of transportation, or they have too much anxiety, or whatever it might be. They won't be able to find it. So there's additional barriers other than the knowledge. So that's what this study is intending to address. Our vision is that consultations happen in primary care, discussion between patient and provider about their needs. Determination is made that such and such resource, and it doesn't have to be specific, it can be very broad, it could be social connectedness. We've had that kind of referral, or exercise. So they identify the patient that would need the resource. The intervention is a patient navigator. So through consultation, we determined that the best way to improve access to the services is to make available a patient navigator in the practice who can then, from the referral, take the patient and help them access the resources. You probably can't see this very well here, but they help them overcome the barriers so they can help. For example, maybe they need to arrange transportation, maybe translator services. They help them with setting goals, encouraging them. They advocate for them when needed. And it's a lot also about empowering them and enabling them, and so that they can feel more empowered after this interaction to undertake some of these things for themselves. So the goal is to reach the community resources, but you'll see that there's this arrow of communication. We wanted to make sure that this was well integrated within primary care. This wasn't going to be another fragmented component of the healthcare system. Okay, our goal is to optimize access to, equitable access to these community resources. So there's sort of two overarching sub-objectives. So one is help the patient get there. That's the navigator I talked about. So, and the second one is to increase referrals. So first, we know that the patient listens, is more inclined to listen to advice when it comes from their provider. So we needed the provider to be, to make that referral recommendation more explicit. So we are providing, I'm going to get to the intervention in 1 second. So we wanted to increase awareness to the patient, to the provider about what exists out there so as to encourage referrals, and then provide support to the patient. So the hypothesis is the providers would be better informed, better resourced. The patients would be better informed, empowered, engaged, supported. They access the community resources, reduce unmet health needs, and increase health. Okay. So the intervention, which is now in the feasibility, and so we're in the field in 4 different practices, includes an orientation on the community resources. So first we tell the practices, these are the resources that are available out there. They might ask some question, well, do you think that might be, we might have something for this, or this would be our priority? And our goal is to motivate them to refer, encouraging them to, if they think there's a need, let us look for it, because there's lots of stuff out there that can help their patient. So the intent here is to make them aware of the breadth of services. And then this similar approach to the patients, and we do this in the waiting room. We have a poster, and we also have this really neat video. I don't know if you're gonna, I don't know if we're gonna show it, but really neat video that we're gonna pilot in one of the practices that shows the resources out there. So it's a little animation and encourages the patient, again, to speak to their provider, because we really want all of this to come through the provider. They're the hub, they're the ones who make the recommendation, and we're there to support the patient. So we want to raise awareness and motivate them to speak to their provider so that they can end up getting a referral. So that's what the poster looks like. Happy to share that with you. Okay, so there's a standardized referral form, so keep that in mind, because that's one of the questions that I'm going to ask you input on. The referral form has 2 purposes, really. One is for us to know what is the patient needing, so that we can actually, the navigator can be prepared and support them. It's for data capture, so we need to know, we need to track what was recommended to them, because in the end, the patient has come to us with a particular recommendation, and once they're meeting with the navigator, they might say, well, I want this and that as well. And if it's not something sort of directly health related, if it's really social support, social networking, we go ahead and do that and support them. So we want to know what they came to us with, and then we're going to see what we ended up supporting them doing. So that's a bit of data capture, but it's also to help the patient have something concrete, which we think is going to sort of solidify the recommendation, remind them of it, and hopefully encourage them to act on it. So the physician at the time, or the primary care provider, anybody who can refer patients at the time of the encounter, if they identify a need, they fill this form, and they fax it to us, and then we contact the patient to enroll them in the study if they're interested. That's what the referral form looks like. We tried actually to make it very similar to the usual referral forms that they might be using in a practice. And the intent is to integrate this, streamline it into what they're already doing, so it's not anything different. Instead of sending them to, you know, to a dermatologist, well, you know, there's recommending a resource, and the same process takes place. And then the navigator. So who's the navigator? There's a lot of studies of navigators out there. How am I doing for time?
10 minutes.
I've taken 10 minutes, or I've got
You
10
have
left?
10 minutes left.
For the whole presentation?
Yeah.
Okay. Okay, so the intervention, so there's lots of jobs out there that include navigation. So care coordinators, social workers, they help the patient with navigation. We wanted somebody who was going to do just that. They're a lay person, they're there to help you connect. They don't need to have a clinical background because they've got these are patients in primary care, they've got the support that they need. We're not taking complex patients that would normally go to CCAC, for example. So it's all the other patients who would need support. And you know, the intent is to help those patients who might have social barriers overcome these and access the resources they need. Okay, so what does it look like? There's a referral made. It triggers the navigator to make the initial contact with the patient. When they do that, they let the provider know, I've connected. Because the providers have said to us, well, I want to know that the patient, if I've recommended to them something important that I would want to follow up on, I want to make sure you're connected. So we tell them that. If there's anything that happens during the navigation period that requires consultation, there's that communication back and forth between the navigator and the provider. And then at discharge, when the navigators finish their job, usually 2 to 4, 6 weeks maybe, if we're still learning, the primary care provider is still. This is just sort of a poster that we're going to put in the encounter rooms and the consultation rooms. All right, so the feasibility study, we're doing rapid cycle evaluation, so we've implemented it in 4 practices and we're looking to see, so how's it going? And we're assessing whether we're likely to have an impact, whether the process is acceptable to the patient, to the provider, whether there's a need for it, are people being referred, is there an impact on the practice? So we're looking at the feasibility of the intervention for eventually running a randomized controlled trial. I ran into your part.
It's okay. I have a cold.
No, you.
No, it's okay.
Okay, you
There's
go.
really not much left.
Oh,
There's really not much left.
Andrea,
It's
I feel
okay.
terrible
It's
now.
okay.
I was supposed to. You should have told me to stop. Yeah. Okay. So there's 4 practices. There's many primary care providers. A lot of these are residents and so on. And we've had. I think we've been open about 5-6 weeks, and we've had 47 patient referrals. 4 are unreachable, a bit suspicious. Are they dodging us? Maybe they really don't want to be reached. That's possible because the provider gets verbal consent for us to contact them to obtain consent. So there's no commitment at this point. 2 have refused. A number have consented, and they're in the process. Many have seen the navigator, and 14 we're still in the process of recruiting. So the intent is to do a randomized controlled trial after, so everything is going well. Things seem to be, there's no major problem. Nobody's sort of concerned about the referral form or about the interaction with the navigator. We're getting really good feedback. Things are going well. Our plan is to do a randomized controlled trial. The intervention here is the same as I've said before. What I want to point out is that in the control arm, we want it to be as usual care as possible. This is where the problem comes. So usual care at this point would be whatever verbal recommendation is usually done. There's usually nothing written, and if it's otherwise, you guys can tell me, but what we've learned is, for community resources that don't require referral, there's nothing written. So that's what we would expect them to do, except that now we would expect them to fill out the form so that we know the patient has been recommended a resource. And then they have to send it to us. And then, let me just see if there's anything else. Yeah,
That's your control group?
that's the control group. And then we call the patient and say, yeah, we've got nothing to offer you, but how would you like, see, so you can see how I'm thinking, but how would you like to answer some questions? And so my concern is that we're introducing something artificial, which is the referral form that they don't normally do for the purpose really of the study. Because at this point, well, we want to know who the patients were, what their profile is, so where's the recommendation so we can compare in the 2 arms. We're not going to act on it. But we also want to get in front, survey the patient pre and post so that we understand whether we've had whether there's a difference between the two groups.
What's your outcome measure?
Right, so the outcome
Because
measure,
that really will
yes,
inform the question you're asking.
very good, very good. So the primary outcome is whether or not they have reached the community resource. In fact, it's not quite that. It's the number of community resources reached by that population. So they might have been referred to one, but they might have access to, whether it's in the control or the intervention.
And you're going to document that how?
A survey. So we ask the baseline survey is, what do you look like? What are your potential barriers? And then there's also a number of measures like the patient activation measure, the HAPA, which is a measure of sort of self empowerment, self-ability, a little bit related to the patient activation, but it really looks at all the different steps that lead to an action. So preparedness, a plan, an action, and all these things. So that's the HAPA. And in the post, we look at whether they've reached the resource, and we deliver the HAPA and the PAM and a number of other quality of life, for example, to see whether there's a difference between the two groups. But the primary outcome is whether or not they've reached the resource. The health impact of that is really, because the resources are so varied, down the road we can't, yeah. So, do you want to facilitate the discussion?
Yeah, sure.
Okay, thank you. And I'm sorry, it's not very fast, thank you.
Okay. So, right now, what the design that we have is a cluster randomized control trial. So, randomizing across practices. Practices would be randomized to the control arm or to the intervention arm. Limited contamination in this design. We'd be able to determine whether increase in referrals was due to the intervention or not, and whether or not access and resources was due to the intervention or not. Some cons, the major con is low engagement on behalf of the providers and potentially the patients. Again, as Dr. Dahrouge mentioned, our provider is really going to refer, use the referral form and refer their patients if there's not a navigator. And what's concerning about this is that right now in the feasibility study, it's very clear that providers are referring because they know that they're referring essentially to a navigator. Having spoken myself with many patients, they know they're getting the navigator. They feel like this is the study, the survey is sort of the one step that's standing between them and accessing the navigator.
And maybe tell them about the baseline.
And yes, so we wanted to capture baseline referral rates to understand, so who are the patient populations that you're referring to these resources, and how much are you referring or recommending these resources without having an intervention, without us giving you an orientation session even on the breadth of services. And when we asked them to do this, one thing is, first of all, it was all paper-based. We didn't want to facilitate the referral the way that we would in the intervention, for example, in uploading it to the EMR. So it was all paper-based, so that was one aspect, but it was really the fact that this was not part of their routine to fill out this form when they make these recommendations, and so most providers didn't do it. And they simply said, oh, I forgot, it's...
Where's the form?
Yeah.
No, really.
Some of them
Like,
have them,
wall.
I
Some of them have them in
Yeah,
their
so
exam rooms.
there's no reason for doing it other than to document for the purpose of the
Yeah.
pre-post assessment.
Yeah, so some of them did have it in their exam rooms, but some said, oh yeah, I guess it wasn't there, so that was definitely a barrier. So the other option that was discussed was randomizing across patients. So every practice that's in the study would be part of the intervention arm, but then it's across providers. One patient gets randomized to the intervention, the other to the control. So a pro for this is, again, we're less worried about providers, the low engagement and low referrals. There'd be balanced numbers across groups. The cons is definitely a higher risk of contamination, and also there's the inability to determine whether or not increased referrals was in fact due in part to the intervention. One thing that resonated with me was potentially, sort of the perception that providers might have where they're referring again with the notion that their patients might get access to this navigator, and if a patient they feel really needs it, and then they get randomized to the control arm, what potential sort of harm or concern that might raise in the providers. But so this was something else that we had discussed, and so we had a meeting with our partners, and we had asked them these questions, assuming that we'd be randomizing across practice, and these questions being how can we keep practices engaged? I mean, a lot of suggestions were about providing them with information throughout the study. So being able to tell them in our intervention arm, these are the resources that patients are being referred to. So they have this constant information that's being given to them that they can also use to refer patients that they are recruiting. So a lot of that was based on, and also providing them with information including 211. So Ontario 211 is a navigation tool that currently exists. It should be usual care that providers say, here's a tool that you can call, that you can go online, where you can better identify a resource in your community based on any barriers such as proximity to the resource, the language, and people can narrow it down for you.
Do people know about 211?
So
It's actually, it's really, it's really good for everybody to know. There's a répertoire of all the resources. Essentially, we're going to rely on that database. And you can search online for the service that you want, or you can call them and they'll assist you. But of course, it's nothing like the face-to-face, the navigator. So they'll do some navigation services, but it won't, they won't be addressing the barriers, trying to elicit it and encourage. But that's a service that is available. People are not using it because they're unaware of it. So I guess one option is in the control arm to have them use 211. So what we want to elicit from you is, without giving too much answers of what other people have said, well, just to kind of keep the slate blank, should we be concerned about physicians referring when it's altruistic? We can tell them, in the end, we'll tell you whether your patient is right or not. That's something you can get. We can give you information about your patients, but there's no intervention to the patient. Can we do something? What can we do to help increase engagement and referral? Because if they don't refer, the problem is not just that we're going to get low numbers in our control, is that in the end, we won't be able to know whether the low referral is due to that's how life goes, they don't refer, or yeah, they do, they just didn't want to document it because there was nothing in it for them. So that's for me a big validity threat. Yeah.
I've done a doctorate or two similar to this type of thing. And there's two key things here. One is the service you're providing.
Yes.
And the second thing is the actual research.
Yes.
So there's two slightly different interests here. So the service is great. Hypothetically, it's something that's required, but I don't know much about in terms of working as a GP. I don't know what services are here, so there is a need. Then there's the research side of things in terms of what's the result, what's the objective, and what is the clinical finding at the end of the day. So there's the evidence base.
Yeah.
Whenever I did something like this before, where I tried to open it up to the population per se, the actual clinical findings are quite skewed because you've got so many confounding factors in terms of what type of populations you may have, what type of problems they may have, and what are the chances of being able to help with such a problem. So I'm thinking along the lines of, in terms of research, you may have to break it down into different population subsets. For example, if you're helping vulnerable populations, maybe one group might be single mothers, for example, one group might be the elderly, and so forth, rather than just having such a broad.
Okay. I'll let Claire Kendall answer that if you have. So this is about, the suggestion is, Claire's a member of our team. Her name flashed up there, I'm sure, very quickly. The suggestion is to focus on a subset of the population, like.
Yeah, we talked about that a little bit, right? I was just actually trying to look something up to see if I could find a good example. I think what we chatted about in our team meeting was that we wanted kind of this to be like a true primary care intervention. So just like, and that's part of the struggle that we end up with so many of our interventions is how do we deliver something that's really.
Like, one of the things you tend to find with multidisciplinary interventions is that you get a negative study because there's just so many confining factors.
Yep.
You know, like, I find that every part of my research in my doctorate was a negative study. It's hard to get published, right? In some ways, as a researcher, you want to get published, but it's a service that you know is helping because you talk to the people positively, and it works. But quantitatively, you have real difficulty making it translate into a positive research finding. And so it's really, how do you get that? So you really have to sort of narrow down what your focus is in terms of, well, if I'm helping this type of person, what's the result?
Yeah, and so we talked a bit about that, and so it was like, kind of trying to develop some list of what would that look like with diabetes, mental health, but I still for me, I ran into that tension, right, of can we just deliver things in the primary care setting that make a difference, and what is that difference going to be, like how are we going to measure that?
Because in fact, there are a lot of navigators that are very, and I should have kind of given you a little more background. We know a lot about navigators, but they're all disease specific.
Yeah.
So either specifically for prevention of breast cancer screening, for example. Sometimes something as broad as diabetes management. Often it's outreach in the community, but there's really no knowledge of this really important services, which is to support primary care and the breadth of services that they give. And so for us, it's important to have that breadth, because or else we might kind of be replicating what's already being done.
And just like, just looking again, right, so many of the patients are overlapping.
Yeah.
And then we end up, so there is going to be a dilution factor with this study, but.
Is the RCT the best way? Like, RCT is obviously the best way to make your point, but is it the best way to do this type of research? Is it more?
That's what I'm just saying, we're having that conversation
Yeah,
too.
it's more a qualitative study as opposed to quantitative.
So that's interesting. And of course, our funder agreed to an RCT. Yeah, please.
So two thoughts. One is with respect to the question we're asking about, how to ensure that you get documentation of referrals in a control group. And I think
Yes.
that's a big issue.
Yeah.
It's almost an ethical issue because you're kind of recruiting people and then offering them nothing. So that makes me think of, would a sort of step wedge design be appropriate where eventually everybody gets something, and people are used to waiting for referrals, so I think that could be built into that. Now, of course, while they're waiting, they're less likely to be trying to access anything. So you have an impact of that
exactly
design.
right.
I don't know. I don't know if there's an easy answer to that. The other point I wanted to raise is the fact that this is done in the context of a research study actually adds an additional barrier, because the step of contacting patients to get consent is a step that is not there in the real intervention. If this were kind of common practice, I would just say, okay, I think we can get some additional help to find you the right resources. I'm going to write to, I'm referring you to a navigator. They'll get in touch with you, just like we do for any specialist referral, right? Referring to rheumatology, they'll be calling you, whatever, and you wait for your appointment.
But in the feasibility, it's not a problem. They're doing it, and the patients.
Well, I'm sort of care to. This is very anecdotal, but I care to disagree because the first and so far, so the only patient I referred to, who was, I have to say, not my patient. I was seeing this lady as sort of an emergency, in an emergency slot for a colleague, and it was all fine when I talked to her. I gave her the package, blah blah, etc. And 2 days later, the nurse says, "Oh, Mrs. So-and-so called and she read through this stuff and she doesn't want to do this."
Yeah.
So that is an additional step.
Yeah.
That is an additional barrier. So just so you kind of, I mean, obviously it's only a minority based on your numbers.
No, but there's a few we haven't
But I'm
yet
just saying
contacted.
you're actually not studying truly the intervention that you would want to be implemented.
But that's true for any study they have to consent.
That absolutely. But I think in this particular case, because we're often dealing with people who are, have all kinds of limitations and have often been resistant to getting additional or receiving additional help. And that's why we pick these people, because the ones who are highly functional, they don't need a navigator, right? So it's kind of a catch-22.
So is there something you would recommend, please?
I'll mention that a lot of the patients, I've spoken to a number of them, they're very enthusiastic about being part of the study. They say things like, I really want to help. This is really exciting. I hope it works. I hope it becomes sustainable. Sustainable, sorry. So the main obstacle is
The control.
It's the survey as well. That is an obstacle for us. But it's not the consent, and it's not being part of the study itself. I think
it's anecdotal, but I can see that there's sort of this
Absolutely.
additional
So not that
barriers.
Esther
It's
and
very
then
difficult to
and
find
then
solutions.
Mom. Yeah, Esther, go ahead.
Just based on previous research that I've been involved, I would also try to use the providers as little as possible.
Yes.
It's, that's the whole reason why you're doing it, because they don't have time for extra steps, especially if nothing gets out of it. I would try
one more form.
that. Yeah.
Okay.
How is it? Would it be possible to go to the resources directly? You wouldn't want to ask for patient data, but I would think ethically it should be possible to get data from them as to where the patients are coming from, so which practice they're coming from. So maybe it would be possible to measure at the level of the resource site if there's been an increase or a decrease from a
Too
specific
broad.
cluster.
Too broad. But actually, you made me think of something, which I'll come back to after we've heard everybody's comment. That, okay, yeah, Mom?
question by Dr. Diane Dalva. Are you including a cost-benefit analysis in your program?
Absolutely. Yes, it's important to determine the economic impact of that.
And a second question by Dr. Bill Hogg. I thank you for your excellent presentation. I find it hard to imagine your providers will fill in the form if they are assigned to the control group. I prefer your option to randomize at the level of the patient despite the possibility of contamination. I recommend a run-in period where all patients are referred to the intervention and then a random assignment of only 1 in 4 to the control group.
Okay, well, that's an interesting, so different balance. I think it'll impact our power.
Can you repeat the last point? Sorry, I didn't hear that.
A run-in where everybody gets the intervention, and then an imbalance, 1 to 4 randomization. So for the, did you have a?
I didn't have a question, but
Oh,
I can
sorry.
have a question. So I know it's virtual care, but would it be possible to have the navigator randomized to, so it would be either in-person versus D211,
So they still see the navigator?
everybody refers to the navigator,
Yeah.
and the navigator would then randomize the patient and say, here's 211, or here are my lovely services. So it's not usual care, but at least you would have an incentive to refer to navigator. Even better, if the navigator actually stays in the office like 1 day a week or whatever, and they get to the doctor's person.
And you would get the baseline information.
Okay, so that's one option. So now we've got 2 options.
My name is Agnes Jamie, I'm an assistant professor in health systems at the Health School of Management, University of Ottawa. And I am a qualitative researcher, so that's my bias in here. And I don't see a solution, but I do see an excellent opportunity to do a full qualitative study alongside of this that could add to the literature on methodology and sort of what you brought up about the problem of all of these non-disease specific multimorbidity trials coming out with negative results. And sort of looking at this as an opportunity to present a problem that we all face when running trials. So interviewing, doing this imperfect control group, and then interviewing your navigator, your control patients, and your providers to then say, what were the barriers, how could we have done this differently, and why it's important. So this is my spin on qualitative research, why it's important to include qualitative evaluations, because we can find that these interventions really are effective in making a difference, but maybe we have to accept that they're never going to give us the p-value that we want, but that doesn't mean we don't want to run interventions for multimorbid patients without putting them in a disease category.
That's great. So that's what we do have. It is mixed method. I didn't emphasize that. So, and in anticipation of a negative trial, I can get a publication on why it's negative. That's what I'm going to say. Who else had their hand raised? Someone in that. What's it, Claire?
I was just thinking, since she's the group, but we're not asking about, are we asking people's ethnicity?
Yeah,
Yeah.
Is it on this form?
In the survey.
so on the
Oh,
survey.
application, right, okay.
The survey.
Good. Yeah, so that makes a difference, right?
So maybe something came to, so I got two suggestions that maybe I can bounce off of you. So I like, so we now have two, but when you were talking, Esther, it made me think about what about if we give the physicians in the control arm, your patients are in the control arm, here is, I'd like to refer you, all they have to do is jot down their name, number, and they give you the 211 card, which could be said what should be usual care or what could be usual care. And we only contact them after 3 months. So he asks or she asks if they would agree to be contacted by the research team. So very little burden, no contact at baseline. We contact them 3 months later and ask them if they went. I don't think that's a huge burden. They don't have to fill out the form. We might miss people, we won't know, but so that's a possibility.
How are you gonna know what they were specifically for? Because
Yeah.
people at 3 months are gonna say, what?
That's true.
Like, what was it? Oh, the doctor said something, I missed it? Like, what was I supposed
Okay.
to do? Like, I don't know, I think you might get a lot
Okay,
of,
so could
sort of
they,
what was this for?
I agree with you, I
question.
agree.
The chart should have it though.
But we can't, it's too much work to go, it's too resource intensive to extract from the chart.
No.
But at least if we ask them to write their name, phone number, and referral. Is
The
that
reason
allowed?
for referral?
Yeah.
Yeah, that could be,
Doable? We pay as well.
And how are you gonna randomize them? Because you're in.
Oh, this is already randomized, these are the control
that would be the
practices.
practice, right?
But see, I think that's also, because doctors are going to be very different in different practices. Some
Yeah.
doctors are naturally going to know more about individuals and others are not.
Yeah.
And, you know, maybe they will cluster within practices they practice similarly, are more interested in this.
Ah, very interesting. So we have
Yeah.
24 practices, but that's certainly not huge in terms of
your idea
balancing.
Actually,
I think randomizing
Yeah.
on the patients more than the practice.
that way, because I
But
think
then-
that approach it takes even more than basically no burden or hardly anything. And it's equal across both
Mhm.
intervention groups. And that's what you want. You want to treat the two
Yeah,
groups as
except that
similar
we
as
now
possible.
had contact with the navigator. So we've now introduced something.
But if you randomize the patient, it's
Yeah,
more,
so
it's
211
more scientifically
or-
rigorous than, because if the
Yeah.
doctors are contaminated, then that skews the practice, that skews the research basically from the very first step.
Yeah, it's actually more scientifically sound to randomize at the practice level. It is, but because there's no risk of contamination, they're not going to learn from the other patients and so on. But it could be an acceptable approach to randomize at the patient.
Research tells us that physicians' behavior is very hard to change, so it's
Yeah.
unlikely that all of a sudden they're going to become superheroes and refer to all those community services, but.
Well, we don't want you to change that.
Exactly.
We want you just to record what you would normally do.
But typically when they're asked to change, they don't change, right? So although there is a risk of contamination,
I see what
so
you're saying.
far,
You're saying that there's a low risk
Yeah,
of
okay, yes.
contamination because of
That's right.
resistance to change.
And that
Yeah.
is what our design specialist tells us as well.
Yeah.
Another option would be to pay the patients, like a token, $15 for their contribution. And the control? No? Oh, interesting.
So because it's not something you're going to be scaling up, it then becomes a different type of comparator. I don't know.
The idea is to see that, I'm assuming you're going in with this with the hypothesis that having a navigator is a really good thing.
Mhm.
So if the physicians refer everybody on a piece of paper to a navigator,
Yeah.
and then the navigator, what you're really asking is the navigator effective?
Mhm.
So if the navigator just sends somebody to 211, there's no navigator. It's just, hi, the doctor referred you, I want to give you the 211, this is what the doctor
Yeah.
referred you for, make sure you ask them this question. So that would be what you would say if you say go to 211. Or the navigator gets really embedded. It seems to take all the onus away from the physicians for ad imaging, for what you're doing, and you're going to do that anyway because you're not going to know which one of them.
Right.
Yeah,
of your patients is getting.
so that we're going back to the randomized at the patient
At the
level.
patient level.
Claire?
I started to have this idea that maybe pay the patients who don't get randomized, but that's not gonna work.
Well, that would be for the, if you did the cluster randomization, you could pay the control patients. So I'll tell you one drawback for randomizing the patient, not the cluster, is that if you randomize the cluster and they're actually doing it the way they're supposed to do, you should be able to tell whether your intervention had an impact on referral rates and then on access when the denominator is those who are referred. Now, we won't know about referral rate. We have actually increased referral rate in the two arms, and now we're strictly testing the navigation component.
You mean referral to the navigator, sorry.
Yeah, well, no, to the community resources, because, you know, they can now feel, okay, I'm gonna refer, they're aware, there's a navigator, maybe they'll get help. They're gonna refer if there's a 50-50 chance, or like Bill was saying, if there's a 25-75% chance, they're more likely to refer. But we've now increased the referral in the control, which is artificial, right? Because in a controlled practice, they're not gonna be referring more because they know their patients are not gonna get anything. Whereas if we're referring at the patient level, yeah.
But you were referred to the services though.
So
That's what I mean.
Yeah. So referral to the resource is not a referral to the navigator. And it's funny because some patients have that misconception as well. Say, yeah, so my provider referred me to you. No, your provider referred you to get this service. We are part of a research team that's trying to see if we can get you better access to that service. But that referral, there's some confusion within patients. They think it's a referral to the navigator. It's not. It's a referral to mental health counseling, to dietitian counseling, you know, and we are a research team that's looking to see if they will be able to access that resource. So the referral is separate from the navigator. Does that make sense?
The navigator refers to resources.
No, the navigator helps them get to the resources. So what we think is by putting a navigator in the practice, the doctor's gonna go, oh, first I know there's a lot more services, I'm gonna refer my patient because there's someone there to help him. Whereas in the control arm, they're likely not gonna increase their referral rates because they know their patients with barriers are not gonna get there anyway. Whereas if we're randomizing at the patient, I can talk to you about that after. If we're randomizing at the patient level, you artificially increase referral in your control. And so we won't be able to tell the difference. How are we doing for time? We're done. Oh. Anyway, I'm here to, it's a dilemma. And I think, you know, it's a huge investment.
Literature on this type of.
Oh, I have looked, and the challenge is, I've read so much, like I've looked for literature, all the literature is on specific conditions.
Yeah.
And when you do that, the design are much easier. Yeah.
I can change
Yeah.
mine. But the refer, like what you're doing is really looking into doing two-stage research project. First stage being what are the referral rates, and then second stage being what's the actual effectiveness of the intervention.
But that's not qualitative.
So
The second stage can be almost really qualitative.
well, the first stage is what are the actual referral
Yeah.
rates, and then
Well, the second stage is utilization, like
Yeah.
actual access.
so then your
which is
second
important.
stage is the actual RCT,
Right.
where you can randomize people.
But in fact, that's what we wanted to do. So in this feasibility, we're actually doing baseline referral, and then we can see what the referral is later. But that's what Andrea was saying, nobody did the baseline referral.
Well, I'm going to say the big challenge is to capture what is the baseline referral.
Yeah.
Because it happens very informally, and you know, looking in the chart, I'm sorry, but when the patient is there with 7 problems, and you go, oh, and by the way, why don't you call 211 for problem number 8? You know, you're not going to document that. Like, there's a lot of stuff that happens that is not. We document the broad strokes, but not every single little detail, and that would certainly fall
And
under.
it would be so much work to
detail.
extract
It would be
it.
impossible.
If anybody gets any other ideas, shoot them our way. It's a huge investment, and I'm really worried about
And it's been funded on the basis of this
RCT.
proposal.
Yeah.
What kind of feedback, did you get feedback in the
No,
identified the.
they didn't identify an issue there.
How many do you need? How many patients do you need?
I think we had said, I don't know, something like 12 practices with, and that's the other thing, is at the practice level, because of the clustering, you don't want to get more than 40 patients because of the intercluster correlation. So we needed 12 practices in each arm.
Anybody know that they're seeing a bid on the order?
No, we were not in the RCT yet, we haven't recruited yet.
Because I really had some meals.
Oh, when you only have 12 practices in each arm, absolutely. We did another study, another clustered study, we had 40 practices and there was some imbalances. So, it's very small for us. Thank you everyone for your